गुड इवनिंग सर।
गुड इवनिंग। आ गए, आपके डर से आ गए।
सर डरने की बात नहीं। सब आपका प्रोग्राम है, सब हम लोगों का प्रोग्राम है। हाँ, गुड इवनिंग अरबट साहब, प्लीज अनम्यूट।
कल कै बजे पहुंच रहे हैं?
राइट टाइम तो सर 11:30 है।
हेलो।
तो
गुड इवनिंग, गुड इवनिंग।
हाँ, ठीक है। मेरी आवाज आ रही है आपको?
आवाज आ रही है, चेहरा नहीं आ रहा है सर।
चेहरा नहीं आ रहा है ना? ठीक है,
हाँ,
ठीक है।
और उसको जो है ये इस पर देख लीजिए सर, स्लाइड आ रहा है कि नहीं आ रहा है, उधर
हाँ,
इट
वो भी
इज।
देख रहा हूँ मैं।
11:30 बजे ट्रेन है।
जी सर।
11:30 बजे।
हाँ, 11:30 बजे है सर।
देवी भाई का
वो तो बोले हैं रात में चलेंगे, आ जाएंगे टाइम पर।
12 बजे बोला है कि 12 बजे तक।
जी जी जी।
इधर क्या कर रहे हैं?
होली के बाद से अटेंडेंस कुछ घटा है?
ऐड करना पड़ेगा।
अच्छा। नहीं,
देखते हैं।
आ जाएगा सर, आ जाएगा,
हाँ,
आ जाएगा। असल है कि लंबा चल रहा है ना, महीना महीना महीना, अभी तो 20 पूरा करने में एटलीस्ट 5 मंथ्स लग जाएगा सर, 5।
यो,
हाँ,
यो,
हाँ। सिंह साहब, मैं दिख रहा हूँ आपको?
नहीं 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 दिख रहे हैं।
हाँ,
ये
अभी तो हमारा
अपना
कैमरा पे।
व्हाट्सएप व्हाट्सएप ये करिए ना, व्हाट्सएप ओपन किए, व्हाट्सएप या जो भी मेल से आए हैं कि किससे आए हैं।
व्हाट्सएप के थ्रू ही आए हैं।
तो व्हाट्सएप में तो व्हाट्सएप ये करिए ना, ओपन करिए।
मैं आईपैड में लिया, इस पे लिया हूँ, लैपटॉप पे लिया हूँ।
नहीं, आप दिख नहीं रहे हैं लेकिन।
हाँ, वही मैं कोशिश कर रहा हूँ।
आपके तो मेल पर भी डाला था मैंने।
वो शटर था।
ये
हाँ,
गुड इवनिंग,
ठीक है।
यस
अभी
यस।
अभी
हाँ, अब
अभी
ठीक।
दिख रहा हूँ।
हाँ, यस
ठीक है।
यस।
फर्स्ट क्लास।
डॉक्टर डॉक्टर तिवारी सर हैं सर।
हाँ, नमस्ते डॉक्टर तिवारी।
नमस्ते सर, नमस्ते।
नमस्ते। हाँ, कैसे हैं आप?
ठीक है, लगे हुए हैं आप लोगों की सेवा में।
हाँ, चलो चलो, अच्छी बात है। इस बहाने आपकी मुलाकात भी हो रही है और आपके साथ जुड़ भी रहे हैं।
थैंक यू सर, थैंक यू।
हाँ, बहुत अच्छा लगा आपसे मिलके। अभी आते थे स्लाइड, अभी स्लाइड्स कैसे आएंगे?
देख लीजिए, स्लाइड देख लीजिए पहले।
स्लाइड्स। हाँ,
यस, इट्स विजिबल सर।
आगे
है ना? स्लाइड दिख रहे हैं ना?
हाँ,
दिख रहे हैं।
स्लाइड शो में डाल दीजिए।
स्लाइड शो में डाल देते हैं। हाँ, ठीक है। स्लाइड शो में है। अब मैं नहीं दिख रहा है पे ना? उनको दिख रहे हैं। ठीक है।
गुड इवनिंग संजय।
डॉक्टर संजय, गुड इवनिंग। अनम्यूट करिए, अनम्यूट करिए।
अनम्यूट करो, अनम्यूट करो।
अरे प्रणाम सर।
प्रणाम प्रणाम प्रणाम।
गुड इवनिंग सर।
गुड इवनिंग, गुड इवनिंग।
गुड इवनिंग एवरीबॉडी। गुड इवनिंग।
गुड इवनिंग।
चलेगा। इसके पहले वाला कंटिन्यू किए हुए थे।
ना तो रहा ठीक से।
छोटा स्लाइड आ रहा है।
तो सर वही स्क्रीन
Sir, we are time is 7:30, sir. Sir, Tiwari sir,
हाँ,
we can start now. Sir, have a few lines of blessings from Dr. Kamlesh Tiwari sir, Dean, Indian College of Physicians. We are continuing this short certificate course under the banner of Indian College of Physicians. Over to Dr. Kamlesh Tiwari sir to say a few words before we start the session.
thank you, Dr. DP Singh. Actually, this short certificate course was started keeping in mind that most of the colleges are not getting proper teaching. And that's why I started this type of course that every student of the country should get at least some knowledge of the topic. And this course is going very well, good attendance, and boys are taking interest. Next step is after checking their attendance, I will invite them for an exam. And after passing that exam, we'll give them certificate. We may give some prizes to them. And I have thought that we may give complimentary registration to those candidates who will score more than expected in the marks as well as in attendance. So we'll see in the end that portion. Thank you. Now we can start our teaching today. Dr. Abrar, please.
Thank you. Should I start it?
Sir. Today's session is none other than our senior and interventionalist pulmonologist, Dr. Ashok Arbat from Nagpur. And he is the chief of the Department of Pulmonology, KRIMS Hospital, Ram Das Path, Nagpur. And he is chairman and managing director, KRIMS Hospital, this Manish Nagar, Nagpur. And his designation is the ex-member of editorial board of International Journal of COPD. So he's an expert in COPD, fellow and member of American College of Chest Physician, president Vidarbha Hospital Association, ex-professor of JNMC Savangi, Wardha, ex-president Vidarbha Chest Association, and ex-president Academy of Medical Sciences in Nagpur. He is member of a host of many national and international respiratory associations, and he has received Star Stalwart of Specialty Award, VIFCON, in Akola, December last. He has also got this Inspiring Chest Specialist of India Times Delhi Lokmat International Award for Health and Wellness in 2020-23, Icons of Healthcare Award for Excellence in Pulmonary Singapore, July 17, and Lokmat Business Icon of Knox. So, Icon of Respiratory Medicine, Dr. Ashok Arbat. over to you. And the topic today is very, very special because if you know the ILD, unless you know ILD properly, you are not a respiratory physician. And the topic is how to approach this, how to classify this, how to clinch the diagnosis, and how to tackle the problem of this interstitial lung disease. Over to Dr. Ashok Arbat, sir.
Thank you, sir, for your kind introduction. I am very happy to join with you, and thanks for giving me this chance to just be with you and just let you know or share my knowledge about the recent advances in interstitial lung disease. Thank you, friends, for joining with me. And today topic is recent advances in interstitial lung disease. You know that interstitial lung disease is a very important aspect of respiratory medicine, and basically it is a uh, heterogeneous, complex group of conditions which are present, characterized by inflammation, fibrosis, or both. And most of the patients they present with the exertional dyspnea, cough, and other symptoms, and sometimes with the constitutional symptoms related to the various type of ILD. Uh, the basic topic is very huge, and that's why I divided in a four group: that approach to the diagnosis first, second is the radiological approach, because without radiology we cannot come to the conclusion, then third is the specific diseases, and fourth is the management. So let us start with this huge topic. I'm sorry that it won't be possible within 1 hour to completely take overview of the interstitial lung disease, since it is a very big topic. But I will try to make it as simple as possible, so that you will have a better approach and understanding about the disease. If some lacunas they are there, then let me know in my presentation. Thank you very much, and let us start. So, introduction. Basically, interstitial lung disease or diffuse parenchymal lung disease. This is a clinical term, diverse range of diseases which involve inflammation and fibrosis in the alveolar, distal airways, and septal interstitium of the lung. Sometimes it is only inflammation, and sometimes it is inflammation and fibrosis. And at the end of the spectrum of the disease, it is only fibrosis which is there.
Sir, your
With
slides are not coming.
slides are not, you are not getting my slides.
No.
Just a minute. Are you getting the slides now?
Yeah. Make it in the presentation mode.
Okay. Presentation mode. ये चल रहा है? नहीं, पीछे जाओ.
Full screen mode.
Yeah, I will. Just a minute. नहीं, इसके पहले. Full screen. Is it okay now?
But not in the full screen mode, sir.
It is my side. It is a full screen.
No, it is not coming in the full screen mode.
Now it is. It is. Are you getting full screen?
Yes. Now it is coming.
Okay. Thank you very much. So we are discussing inflammation and fibrosis, which are present in the alveolar, distal areas, and septal interstitium of the lung. Septal interstitium are part of the distal part of the lung, where the alveolars are involved. The histopathological changes which we see in the ILD from the just cellular ILD to fibrotic ILD. So it is a granulomatous inflammation which we can see more in the sarcoidosis to the extensive pulmonary fibrosis, which we with the architectural distortion, which can be seen in idiopathic pulmonary fibrosis. There is some specific link to the genetic abnormality which is also established about the IPF. The clinical spectrum of the ILD India, it is very important because our spectrum is very difficult, that different than the spectrum which are seen in the Western countries. So distribution is idiopathic pulmonary fibrosis and or hypersensitivity, which is seen in 43 to 46%. Sarcoidosis is 22%. ILD secondary to collagen vascular disease 18%. Extrinsic allergic alveolitis is 16%. This data is totally different than the international data. This is a data taken from the registry of the ILD India. Now there is another term called as a progressive fibrosing ILD. Basically, it mimics like a IPF, but it is different than the IPF. The non-IPF ILD that believed were most likely to have a progressive, and the progressive lead to the fibrosing phenotype, like which we see in NSIP, systemic sclerosis ILD, then unclassifiable IIP, RAILD, and this is around 18 to 32% of the patient diagnosed with the non-IPF ILD. That is, earlier they are like a NSIP, but later on develop into progressive fibrosing phenotypes, and this is the another group. So let us start with the approach to the diagnosis. If you really want to know about the how to approach the diagnosis, then we need to a complex need to understand the disease. This is a complex heterogeneous group of more than 150 to 200 type of disease, and characterized by a spectrum of inflammation, fibrotic changes, which we have seen in alveolar, airspace, and distal airways. As far as significantly respect to the this differ significantly in respect of prevention, therapy, and prognosis. Clinical manifestation in almost all diseases are very similar, like progressive dyspnea, parenchymal infiltration, distressing cough, pulmonary dysfunction, inability to perform the regular functions, and some other like which are seen in the connective tissue disorders like a rheumatoid arthritis function presentations. Now, the interstitial lung disease, diagnostic strategy wise, it is a dynamic presentation, maybe acute, subacute, or chronic, which we see in the hypersensitive pneumonitis. Some causes are known, some are unknown, which we see in the next slide. And there is a involvement of pulmonary architecture as well as sometime involvement of the extrapulmonary and systemic involvement also. The interstitial lung disease category wise, known cause, that is drug induced or connective tissue diseases, unknown cause, that is idiopathic interstitial pneumonia, that is called along with IPF, NSIP, RBILD, discriminating interstitial pneumonia, COP, AIP, and LIP. Then miscellaneous may be that is LCH. LCH basically Langerhans cell histocytosis, LAM. This is a lymphangioliomyomatosis, and some granulomatous disease like sarcoidosis, hypersensitivity, pneumonitis. Before I going to further, I will let you know about unknown causes that we have seen NSIP, non-specific interstitial pneumonia, RBILD, it is respiratory bronchiolitis ILD, DIP is a discriminating interstitial pneumonia, IPF, it is a idiopathic pulmonary fibrosis. LAM is lymphangioliomytosis. LCH is Langerhans cell histocytosis. LIP is lymphoid interstitial pneumonia. These are the long terms of the. In the next further lecture, we'll use this as short form of the disease. So clinical evaluation history is very important. Like we have to ask when it has occurred, how it has started, history of exposure to any allergen, exposure to any interstitial fume, severity of symptom at time of the present, then whether it is acute, subacute, or chronic. Whether it is episodic symptom wise, then we have to see X-ray and the opacity is seen in the CT scan also. Assessment of the symptoms is very important thing because assessment will show the severity of the disease, whether it is acute, subacute, or severe. So dyspnea is one of the very important symptom in assessment of the disease that will be assessed with the help of pulmonary function test, diffusion studies, and 6-minute blood test. Cough and wheeze that can be judged along with the history. Pleural pain and effusion that can be judged along with the X-ray and important investigation. Hemoptysis can be judged with the bronchoscopy. Gastroesophageal reflex, the history will suggest you, or sometimes you may require a gastroscopy, and the extrapulmonary features that will be assessed by with the various blood investigations. Then comprehensive investigation like causative agents that will be seen with along with the history, whether it is allergens, it is the fumes, it is the organic dust which are involved. Comorbidity disease like esophageal reflux, carcinoma is there, OSA is there. On physical examination, laboratory testings that is we have seen. Then spirometry, 6-minute walk test, radiological assessment, bronchoscopy, and cryobopsy. These are the physical investigation where we need to have a specific type of ILD and histopathological evidence. Histopathological evidence only collected with the bronchoscopic biopsy, cryobiopsy, surgical lung biopsy, and sometimes we need to assess the severity of the pH with 2D echo. Investigations, exposure in past and present, and then certain things like a smoking which will be influencing for the exacerbation of the disease. Then hobbies, whether patient is working in the industries, whether he has got some hobbies, he is having some birds he is keeping with him, any travel history to the specific location. Then the occupation where the industries or diseases are very common. Drug history, radiation therapy in case of the patient is suffering from any chemotherapy, and the family history, which is very important in RA-ILD, connective tissue disorder, and idiopathic interstitial pneumonia. Comorbid infections like sometimes the disease associated with tuberculosis, cytomegalovirus, pneumocystis. So these are important in the investigation. Connective tissue disease, we know rheumatoid arthritis, systemic sclerosis, scleroderma, polymyositis, dermatomyositis, Sjogren syndrome, and SLE. In vasculitis, Church-Strauss syndrome, then micro polyangiitis. There are some useful laboratory tests to differentiate or to know about certain connective tissue disorder. If you are suspecting the CTD or connective tissue disorder, idiopathic ILD, then we need certain investigation like ANA, RA, anti-CCP, dsDNA, and certain further ANA blood test also. If you are suspecting myositis, then creatinine kinase activities. If you are suspecting immunodeficiency, then immunoglobulins are important in this matter. Some useful, if you are suspecting vasculitis, then CNCA, PNCA are the important test we have to do. If you are suspecting hemoptysis due to DHA and renal failure, then anti-glomerular basement membrane antibodies we have to see. If you are suspecting sarcoidosis, serum AC is very important. And if you are suspecting hypersensitivity pneumonia, then exposure to any specific antigen. So the specific IG antibodies are very important, and that will better for the interpretation of the disease. This is particularly applicable if you are suspecting connective tissue disorder, and then you want to segregate whether it is SLE, whether it is polymyositis, whether it is dermatomyositis, it is systemic sclerosis or Sjogren syndrome. Then ANA blood test is very important, which will guide us about the further disease. Now, the basic thing which we have is the X-ray. X-ray gives lot of information about the disease. If X-ray we can see the lung volume is reduced, then we can suspect it that IPF, CTD related ILD, or HP, asbestosis, chronic drug induced fibrosis. If lung volume is preserved or increased, then we can suspect RBILD, IPF plus emphysema, where the lung volume is increased. Then LCH, LAMP, sarcoidosis, tuberous sclerosis. This we can consider from the increased lung value. When it is seen as in a X-ray upper zone predominance, then we can suspect sarcoidosis, silicosis, cold working pneumocolitis, HP and LCH, CEP. If it is lower zone predominance, we can suspect it is interstitial pulmonary fibrosis, CTD associated ILD, asbestosis, DIP, and chronic HP. Peripheral predominance is seen in X-ray in IPF, COP, and CEP. Micronodules can be seen on the X-ray in sarcoidosis, some infection, uh, then uh, malignancy, and hypersensitivity pneumonitis. Septal thickening is seen in malignancy, chronic LVF infection, pulmonary veno disease. Then other things which will be seen either in the X-ray although or the CT also, that is honeycombing. Honeycombing, we can suspect or we can diagnose interstitial pulmonary fibrosis, asbestosis, CTD related ILD, chronic HP and sarcoidosis. Migratory opacities we can see on the CT or X-ray, then definitely we can consider lobular disease, cough, hypersensitivity pneumonia, and ABPA. Pleural involvement is there, like pleural effusion is there, pleural disease is there, then we can confirm that it is CTD related ILD, asbestosis, malignancy, or radiation induced ILD and sarcoidosis. If it is presented with a pneumothorax, then lymphangiomyomatosis, then tuberous sclerosis, neuropybrosis, and LCH we can consider. If there is a hilar lymphadenopathy or mediastinal lymph node are enlarged, then we can consider sarcoidosis, malignancy, silicosis also. And sometimes we can get a normal X-ray also. The ABPA is allergic bronchopulmonary aspergillosis. About the HRCT, same thing we can consider in HRCT. When we see the centrilobular nodules, air trapping, ground glass opacities, relatively sparing bases, that is most likely to be hypersensitivity pneumonitis. When there is a pleural effusion, pleural thickening, esophageal dilatation, we can consider choralgia vascular disease. With pleural plaques, pleural thickening, definitely we can suspect disease like asbestosis, and focal abnormalities, that is because of the some localized scar because of the last previous infections. Now we'll move to the second part of the lecture, that is a radiology approach to the ILD. The radiology is very important thing because most of the time we have to diagnose ILD on the basis of radiology or CT, because it is sometimes impossible to perform the histological diagnosis by doing bronchoscopy or cryobiopsy or open lung biopsy. And sometimes history may not be relevant, sometimes history may not be given by the patient, and the symptoms are same. We can see that is exertional dyspnea, cough, chest pain, hemoptysis, pleural effusion, which we can see in any disease also. So naturally, if we want to the close to the diagnosis or differential diagnosis, we need to rely on the radiological approach to the ILD. And that is why reading about the CT scan, X-ray is very important for the physician, because where you can have your own impression about the ILDs and you can diagnose the ILD. So let us go some detail about the radiological presentation. So radiological approach, clinical presentation, I told it is a mostly similar, each having unique radiological manifestation. HRCT is the tool where we can narrow down the diagnosis. There is no gold standard diagnostic test for the ILDs. So multidisciplinary approach is involved, where the radiologist, physician, then pulmonologist, maybe sometimes the rheumatologist help is required to diagnosis for the diagnosis. Now, the radiological approach to ILD, what is the basic architecture involved is the interstitium. There are three parts of the interstitium. One is the axial interstitium, second is the peripheral interstitium, and third is the septal interstitium. That we'll see in the later slide. Lung parenchyma, which is presented in the ILD, is a predictable response to the injury. It may be either inflammation or it may be fibrosis, or there may be overlapping imaging finding which can see in the lung parenchyma. So other than the lung parenchyma, it is a very important to know about the interstitium so that we can diagnose ILD with the basis of interstitium involvement. Now, whether we have to see whether the lung volume are increased or lung volume are decreased. When the lung volume are increased, there is a decreased attenuation. There is a air trapping and emphysema that we can see the patient with the HP and the IPF along with the COPD. Then lung volume is decreased with the increased attenuation that can be produced by reticulation and honeycombing. That we can see the patients with the interst, uh, interstitial pneumonia or patient with the chronic HP, patient with the IPF, and patient with the uh, other interstitial chronic interstitial lung disease. Now, this is the basically for the knowing for the students. This is the presentation of the CT in the diagram. So here you can definitely know what are the interlobular septal thickening, how it appears. Then the parenchymal bands, which see the next. Then intralobular interstitial thickening, which can we see. Then fissural thickening due to subpleural interstitial thickening. Peripheral honeycombing producing subpleural line. Then there is a fibrotic band without honeycombing, bronchiectasis, traction bronchiectasis, and centrilobular peribronchovascular interstitial technique. This is how the same thing we can see in the CT also. This is how the smooth interlobular septal thickening in pulmonary edema. This will give us idea about how the interlobular septal thickening we can see. Now the second is reticulation or reticular opacities, which we can see in the CT. What are these reticulation or reticular opacities? A net-like pattern, thicker interlobular or intralobular septi connecting and interbridging with one another, mostly peripheral and basal lung zones. This is how the intralobular septal thickening is in patient with the pulmonary edema. Just for the knowing how the interlobular septal thickening is seen. Now the ground glass opacity. On the right side of the image, you can see the various type of opacities seen in the, they are known as the ground glass opacities that are increased attenuation. Not dense enough to obscure the underlying bronchoscopal marking, airface disease, alveolar collapse, interstitial thickening, and increased vascularity of alveoli is preserved in this disease. This is how the ground glass opacities are seen in the CT scan. Now, the consolidation, the increased attenuation, consolidation, area of increased attenuation, inability to visualize by marking the affected areas, result from filling of the air spaces with fluid, edema, or blood. And the right side, we can see the patchy region of the consolidation in the patient of the ILD. Now we have to differentiate reticular opacities. We have seen the ground glass opacities and we have seen the consolidation. Now let us see that how we can diagnose various type of ILD if the reticular opacities are there. If the reticular opacities are there, it is more fear of usual interstitial pneumonia, non-specific interstitial pneumonia, particularly chronic type, collagen vascular disease, asbestosis, and drug-related pulmonary fibrosis. If there is a ground glass opacities, they are more in favor of non-specific interstitial pneumonia, acute or subacute uh, acute interstitial pneumonia, discriminative interstitial pneumonia, RBILD, LIP, cough, subacute HP, and acute exacerbation of the ILD. When there is a consolidation, then we can consider disease like cough, polymyositis or dermatomyositis. Acute exacerbation of ILD is important thing. Many times when we get acute exacerbation, we see the secondary consolidation. Then acute interstitial pneumonia, acute HP, drug and sarcoidosis. Now we'll see the nodular opacities. Nodular opacities are three types: centrilobular, perilymphatic, and random type. These are shown in the lower image where you can see the various type of opacities. Few millimeter up to 3 millimeter, greater than 3 centimeters is referred as mass, and the various type of opacities will give the particular clue about the disease. This is how the centrilobular random nodules are seen or opacities are seen. Now, these small nodules, whether it is centrilobular, it is a perilymphatic, very random nodules, that we can differentiate in different disease. It is a centrilobular opacity, that is subacute HP, RBILD, Langerhans cells histiocytosis. It is a perilymphatic, very classical of sarcoidosis, silicosis, coal workers pneumoconiosis. Random nodules can be seen in hematogenous metastasis, miliary fungal infections, then silicosis, biliary tuberculosis also. Then linear opacities that we have seen the first first slide. That is, I will show you the linear opacities. These are the linear opacities like the bands. The linear opacities are an interlobular septal thickening, parenchymal bands, subpleural curvular densities, intralobular septal thickening, and this is seen in like this. These are the interlobular septal thickening and parenchymal bands. Another is decreased anatomy honeycombing. Honeycombing is a cluster cyst usually stacked together in one or more layers. See, important, they are stacked together, they are present one or more layers. They are always, most of the time, subpleural. 3 to 10 millimeter thick at uniform size. So we have to differentiate this honeycombing from the cyst, and that represent the destroyed fibrotic lung or loss of lung architecture. If the honeycombing is there, then subpleural honeycombing or posterior lower lobe predominant honeycombing is mostly seen in idiopathic pulmonary fibrosis 70%, collagen vascular disease, drug-related fibrosis, asbestosis, and chronic HP. Upper mid lung or peribronchial predominance of honeycombing, that is seen in chronic HP, sarcoidosis, radiation, fibrotic ARDS, and IPF. Then atypical finding also presents, that is DGOs, nodules, consolidations, cysts, mosaic perfusion, air trapping, that is the interstitial pneumonitis other than the UIP. This is how the honeycombing looks on the left side of the image, and this is how the cysts are seen in the right side of the image. This is how we have to differentiate it from the bronchiectasis. This is how the traction bronchiectasis is seen on the right side image, and honeycombing as usual seen in the left side image. Then non-specific cysts are seen on the right side. Emphysema, it is typically sometimes we mistake for the honeycombing, but emphysema cysts are very different, and they are not stack-like and they are not subpleural. They are present anywhere in the lungs. This is the paraseptal cyst, which we can see differentiate from honeycombing. And this is the now we'll go next to the cyst, how cyst is appear and how we can differentiate cyst also. This is the cystic presentation of the image, which we can see in the CT scan. Cystic bronchiectasis, signet ring type of presentation, cylindrical bronchiectasis, honeycombing, lung cyst, centrilobular emphysema, panlobular emphysema, paraseptal emphysema, and mosaic patterns. Now we'll see the cyst. Cysts are basically the rounded areas of low attenuation that are well demarcated from normal lung parenchyma by a thin wall. The wall are less than 2 millimeter thick. That is how we can differentiate from the honeycombing. This is the HRCT image showing the thin wall cyst, which we can see in the lab. Now, the diagnostic consideration, if there are cysts, if there are perilymphatic nodules, if there are centrilobular nodules, tree inward appearance, mosaic attenuation, how the CT finding will help us for the diagnosis. So, when there are cysts which are diffuse present in the lung parenchyma, definitely we can consider Langerhans cell histiocytosis, LCH, lymphangioliomyomatosis, lymphoid interstitial pneumonia, bird hog dupe syndrome, perilymphatic nodules which can be seen in sarcoidosis, very classical, chronic beryllium disease, lymphangitic carcinomatosis, and lymphoma. Centrilobular nodules can be seen in HP respiratory bronchiolitis, tree-in-bird infection, all we know that. Mosaic attenuation is seen in HP obliterative bronchiolitis and pulmonary thromboembolism. Then we have to differentiate honeycombing and cyst also. The honeycombing is common in some diseases, cysts are common in some other diseases. Honeycombing, we know it is the UIP, IPF, fibrotic NSIP, drugs, lead, asbestosis, sarcoidosis, chronic HP, collagen vascular disease. Cyst we can see in Langerhans cell histiocytosis, LAMP, LIP, DIP, Bird Hawk Duke syndrome, and light chain deposit disease. Now we will go to specific disease. First, we'll start with the rare disease. Then we'll uh, go for the specific disease. First is the Langerhans cell histiocytosis, that is a LAMP. Basically, it is a smoking related strong association with the smoking, mostly thing in the young adults. Later life granuloma replaced by the fibrosis, cavitate, and cavitary form is seen Langerhans cities. HRCT multiple irregular cysts or nodules are seen. We have seen CT of LCH. Cysts are irregular shape, thick or thin wall, classically affect more in the upper zone of the cells. And this is a granulomatous disease when unknown causes. This is how the LCH cysts are seen. This is with a small nodule, cavitary nodules, and cyst. This is how nodular LCH in 30-year-old man, and this is a HRCT presentation at the level of right upper lobe bronchus. Now the second is LAMP. Again, it is cystic disease where the thin wall, multiple uniform, diffuse without any specific regional distribution. So diffuse cysts are seen in the lab. Cysts are size from 2 to 5 millimeters in size, rounded, oval shape. Remaining lung parenchyma normal, rarely few scattered centrifugal nodules may be seen. It is idiopathic secondary to the tuberculosis, and this is how the CT which we can see in the lab. Now, lymphoid interstitial pneumonia, another cystic disease, idiopathic rare disease, secondary to lymphoproliferative disorders, and immunodeficiency stage like a Sjogren syndrome. HRCT shows diffuse or lower lobe predominance, ground glass septal thickening, centrifugal nodules, perivascular, some pleural cysts are seen in this disease. Light chain deposit disease, again, this is cystic form of disease, rare form of cystic ILD. Patient with plasma cell dyscrasis, multiple myeloma, B cell lymphomas, and HRCT showing the parenchymal distribution, cystic and nodular changes. Nodules are 2 to 5 centimeters in size. Burt-Hawk Dupe syndrome, rare disease, autosomal dominant, multiple systemic involvement like skin, lung, and kidney. It is a facial fibro, folliculomatous malignance, and renal tumors are seen. HRCT again cystic changes, multiple thin wall cysts from 2 centimeters and more than 2 centimeters. This is how the cysts are seen in the Burt-Hawk Dupe syndrome disease. Then the idiopathic interstitial pneumonia, which is the most of the common disease which we come across, because 50 to 60% of the ILDs which are seen the idiopathic pulmonary fibrosis, it is the most severe form of the disease, and the prognosis is very bad in this disease. Usually 2 to 4 years, if the patient is untreated, it has got a bad prognosis. Mostly seen in the elderly people more than 60 years. There is a history of family history, maybe sometime associated because it is a familiar. It has uh, associated with the familial history and associated with the fibrotic changes. High risk of bronchogenic carcinoma is seen, characterized by UIP pattern. Without alternative diagnosis, we can diagnose the things. There are few criteria which we'll see in later. HRCT shows typical presentation of the subpleural apicobacterial grading, honeycombing, peripheral reticular opacities, traction bronchiectasis, and minimal ground glass opacities. Lower lobe volume loss is seen in these patients, and this is how we can diagnose the idiopathic pulmonary fibrosis, one of the most severe type of interstitial lung disease with a very bad prognosis, seen in the mostly in the smokers, male population above the age of 60, and having some genetic predisposition in the disease. This is how the CT scan is seen. The you can compare the CT scan along with the lung specimen. Lung specimen also shows the similar type of honeycombing in the lungs, and from where the CT scan presentation is developed. This is how the various type of honeycombing is in a IPF. What are the diagnostic criteria of the IPF? The four features are very important: subpleural basal predominance, reticular abnormalities, honeycombing with or without traction bronchiectasis, absence of features listed as inconsistent with the UIP pattern. These are the UIP patterns. So, what are the seen in the UIP patterns? Mostly they will be seen the IPF also. Then, if is a possible UIP pattern, then subpleural basal predominance, reticular abnormality is seen. Absence of feature listed inconsistent with the UIP. There may be reticular pattern or there may not be traction bronchiectasis. If the traction bronchiectasis is there, there may not be honeycombing even. Now we will go to the more common type of non-specific interstitial pneumonia. As the name suggests, it is a non-specific. When the ILD research was done in very early days, they have seen there are some CT scan showing very specific involvement of the lung parenchyma and interstitium. So they are called the UIP pattern, usual interstitial pneumonia. But when there is no usual pattern is seen, they have seen non-specific interstitial pneumonia, and these all diseases are called as a non-specific interstitial pneumonia. More common caused by the many different disorders, like it is seen in hypersensitivity pneumonia, CTTs, and drug-related disease. HRCT, widespread bilateral ground glass opacities, peripheral linear or reticular opacities, peripheral basal distribution, subpleural sparing is seen, which is not seen in IPF. Sometimes micronodules or foci consolidation are seen in NSIP. The most common example of NSIP is hypersensitivity pneumonia. And hypersensitivity pneumonia is very common in India. So that we can see there are over 200 antigens have been identified, including the fungi, bacteria, protozoa, animal proteins, low molecular weight chemicals, which are involved in the HP. They are the causative agent of the HP or hypersensitivity pneumonitis. Uh, and this is because of the inhalation of the allergens, which triggers the complex immune response in the lung parenchyma. There is a ILD in India registry shows that 47.3% of the patient with new onset of ILD in India were diagnosed with the HP. So India is very common in India. HP is very common as compared to the European countries or the other countries. Now, hypersensitivity pneumonitis, that is HP, it is a granulomatous immunologic disease, response to various environmental antigen. It may present like acute, subacute, or chronic. All three stages may be having a significant overlap. Acute HP is the fevers after antigen exposure showing homogeneous or heterogeneous opacities. Subacute is an intermittent or low dose antigen exposure, and chronic HP is a long term antigen exposure. And mostly it is a fibrotic pattern resembling like UIP or a fibrotic NSIP. Again, there is the antigen interaction, humoral response, B cell, granuloma formation, and fibrosis seen in the chronic type. There are various type of agents which are involved in the antigens like bacteria, fungi, yeast, mycobacteria, animal proteins, and the chemicals. And the specific antigen is given, the source is given, and the type of disease are given. Like if it bacteria is involved, is a farmer's lung. If it is fungi is star lung, it is also called farmer lungs or mushroom workers lung, like this. General symptoms in the HP are cough, exertional dyspnea or shortness of the breath, fatigue and malaise. Chills, if it is acute presentation, subacute presentation, with a fever with chills, flu-like symptoms are very important, and a chest tightness will be complained by the patient. In chronic, there will be a progressive dyspnea, weight loss, chronic respiratory insufficiency, and maybe you can get a crackles or auscultation, which will be presentation of pulmonary fibrosis in severe cases. Then there we can differentiate non-fibrotic HP from fibrotic HP. Non-fibrotic HP basically acute without constitutional symptom. Fibrotic HP insidious onset with setting of the specific exposure history. HRCT mostly non-fibrotic HP will be GGO, mosaic attenuation or the abnormality suggestive of the cellular NSIP. And in fibrotic HP, there will be irregular fine coarse reticulum, architectural lung distortion, septal thickening, traction bronchiectasis, honeycombing, and GGOs are seen. So that is how we can differentiate um, fibrotic and non-fibrotic HP from the CT scan. Again, the same features we can see in the chronic HP and acute HP. We have also seen many. We have got a clinic called as a ILD clinic, and we have total registry of around 751 patients with us in our ILD clinic, which are coming regularly for the last few years. Male around 55%, female 45%. Age distribution is concerned, 51 to 60 year 21%, above 61 years 62%. So 80% of the patients presented in our ILD clinic are above the age of 50, and only 30% of the patients are below the age of 50. Distribution of the various ILDs, UIP more or less is 41%, NSIP, which is present earlier form of the disease, 24%, HP, that is a chronic HP, is 18%, RAILD 9%, IPF 5%, CTD 4%. So this is how our ILD clinic shows the various types of ILD and their distribution in the patients. Now we will go to the further disease, that is cryptogenic organizing pneumonia. Basically, this is a present like a consolidation, idiopathic bilateral, multifocal, patchy consolidation, and ground glass opacities. Lung value usually is preserved. Subpleural bronchovascular involvement, lower zones tendency, migrate after therapy. HRCT shows the reverse halo or at all sign. RBILD, it is again smoking related disease. HRCT shows the ground glass, more patchy, less extensive involvement, upper lobe, centrilobular nodules. Small cyst formations are seen in some patients. Many have concomitant upper lobe emphysema also. Then discommitted interstitial pneumonia, a rare presentation in 40 to 50 years of the age. Men are affected twice as compared to the female. More in the smoker, 90% of cases are smoker. Also secondary to lung infection, organic dust exposure. HRCT show ground glass pattern, more in the peripheral basal lung zone. Some cases shown small thin walled cyst less than 2 centimeters. And this is how the presentation of the CT in discommunicating interstitial pneumonia. Acute interstitial pneumonia, acute presentation, patchy ground glass, traction bronchiectasis, artificial distortion. Some cases we may get a consolidation. Prognosis progress to chronic fibrotic phases, and this is how the acute interstitial pneumonia we can see in the HRCT. Asbestosis is the occupational lung disease. Mostly patient with present with us with the fibrosis because of inhalation of the asbestos fibers when they are working in the industries. Average latent period for the appearance is 20 year. HRCT shows early stage of multiple subpleural nodules, patchy ground glass opacities, multiple septal thickening, and reticulation. In advanced stage, there will be like in UIP pattern bases or subpleural dominant disease and pleural plaques are seen. And this is how the subpleural lines are seen in asbestosis, and how we can differentiate in scleroderma also. Then silicosis, another occupational disease, most common occupational disease, inhalation of silica dust exposure, foundry workers, ceramic manufacturing workers. It is an acute or chronic form. HRCT shows multiple diffuse nodules, centrilobular, subpleural, small 2 to 5 millimeter. Calcification may be seen in some nodules, and there will be a mediastinal lymphadenopathy. This is how the perilymphatic nodules in silicosis. Now, coal worker pneumoconiosis, particularly seen in the coal workers where they are exposed to the washed coal, leads to interstitial lung inflammation and fibrosis. This is a presentation is just like a silicosis, and CT scan is also more or like a silicosis. This is how we can see the nodular pattern and ground glass opacities in subacute HP. And this is how we can differentiate in chronic HP with the reticulations, then interstitium involvement, but subpleural sparing is there, and somewhere honeycombing and traction bronchitis is also seen. Another disease is sarcoidosis, is a multisystem inflammatory unknown cause. Multiple non-caseating granulomas are seen in sarcoidosis. 20% develop chronic fibrotic lung disease. Preferably, upper zone is involvement. Multiple nodular opacity is perilymphatic, which is very common. Interstitial septal thickening, nodular linear opacity, alveolar opacities are seen. Honeycombing traction bronchitis are seen in a chronic type of disease. This is how the random distribution of the nodulars in sarcoidosis in the acute or subacute cases or early stage of the disease. Then another is berylosis, uncommon ILD caused by beryllium dust or fumes. Workers in nuclear industries, ceramic manufacturer, and acute or chronic stage. HRCT showing chronic stage resemble like a sarcoidosis. Now, what is the pathophysiology or pathogenesis of the connective tissue disease? The pathogenesis of CTD-ILD is unknown. However, many factors can either cause or exacerbate ILD in patient with the CTD. There is a immunological factor, there is a genetic factor. Immunology factor is formation and deposition of autoantibodies against a cellular component are seen in the lung interstitium, which highlights the important role of the autoimmunity or pathogenesis of the CTD-ILD in SLE, RA, and systemic sclerosis. Genetic factors are also involved, like HLA-DR4, HLA-DR1 polymorphism have been found in many RA-ILD patients also. Now we'll go to the most common type of ILD, that is rheumatoid arthritis ILD or RA-ILD. Is the most common CTD and characterized by the erosive inflammatory polyarthropathy with symmetrical arthritis and range of pulmonary manifestation. While RA occurs more commonly in the female, that is 3 times more common in the female, but RA-ILD is more frequently seen in the males also. The prevalence is 5 to 58% depending on the cases of identification. Although it is common form of ILD to be diagnosed concurrent with or after RA, population-based studies suggest that 3.5% of the patient with RA are given diagnosis of ILD prior to the diagnosis of RA. So ILD is first manifested before the manifestation of the RA. Smoking is an important risk factor for the ILD. RALD mostly chronic form manifest as the UIP pattern, less commonly with the NSIP pattern. Patient with RA with usual interstitial pneumonia pattern in HRCT worsen survival compared with those with a non-specific interstitial pneumonia. Then rheumatoid arthritis, this is how the HRCT shows the bronchial wall thickening, bronchiectasis and nodules are seen. Less common non-septal thickening, ground glass reticulation, honeycombing and consolidation. Common pattern in UIP or sometimes in NSIP. Systemic sclerosis, rare connective tissue disease, cellular inflammation and fibrosis of the skin and multiple internal organs. Patient with systemic sclerosis may be classified as having limited disease or extensive disease. This is how the systemic hilar ground glass opacities are seen represent the pulmonary hemorrhage in patient with the Wegener granulomatosis. Mixed connective tissue disorder, overlapping symptoms are there. The features may be SLE, maybe dermatomyositis, maybe RA. HRCT shows ground glass opacities, subpleural nodulars, reticular or linear opacities. Sjogren syndrome, chronic inflammatory condition characterized by lymphocytic infiltration of exocrine glands like salivary and lacrimal glands. It occurs either in population primary Sjogren syndrome or secondary Sjogren syndrome. Then SLE, multisystem disorder affecting joint, skin, kidney, CNS, serosa surface of the internal organs like heart, lungs, and abdomen. Almost all patients are showing NA positive. Respiratory symptoms associated with SLE are often absent. Abnormal PFT or HRCT may be sometimes give clue about the early stage of SLE. The prognosis is significantly worse in patients with experiencing pulmonary complications. Clinical significant ILDs affect only 3% to 8% lupus population. A drug-related ILD, wide variety of pulmonary manifestation, non-specific and overlapping. Drugs which can lead to ILD are amiodarone, which is used in the lung, in the heart cases, bleomycin, cyclophosphamide, methotrexate used in the some cases with the chemotherapy, nitrofurantoid, and nitrosources. This is how the drug-related ILD NSIP pattern in 46-year-old me treated with bleomycin. Now we'll go to the last part of the lecture, that is the management. There are few strategies with the management. The treatment, it is not the only pharmacological treatment. Along with that, we need supportive treatment to relieve the symptoms like cough, anxiety, depression, dyspnea, and we have to treat the comorbid conditions also. Then immunosuppressive drugs are most commonly used among with in immunosuppressive drugs. Corticosteroids are strongly associated with the improvement and clearing of the lung pathology in most of the ILDs. That is NSIP pattern or non-fibrotic pattern of the ILD. The common example which are treated with the corticosteroid are cryptogenic organic pneumonia, that's cough, eosinophilic pneumonia, sarcoidosis, and cellular type of NSIP. There are various therapies for selected type of ILD in IPF sarcoidosis, various drugs which are used, anti-reflux measure, anti-reflux surgery, and acid suppressants. Now, antifibrotic agents which are seen in IPF patients. The pirfenidone and nintedanib are currently approved antifibrotic agent, major mechanism by which they modulate the step in the cycle of lung fibrosis and reduce the lung fibrosis or stop the further fibrosis in the interstitium. Now, first we'll see the nintedanib is a multiple tyrosine kinase receptor blocker. Basically, it protect from the PDGF, that is platelet derived growth factor, vascular endothelial growth factor, and fibroblast growth factor. It slows the rate of disease progression in IPF, which we can measure with the help of um, diffusion defect or vital or post vital FVC. Standard dose is 150 milligram twice daily, approximately 12 hours. Liver dysfunctions are liver function test to be done before starting the drugs. Moderate to severe hepatic impairment is there, should not be started with these drugs, and we have to monitor regular LFT in these patients. The more frequent adverse effects are seen: diarrhea 62%, nausea 24%, vomiting 12%, elevated LFT is 14%. If it is a systemic sclerosis associated interstitial disease, then of course the strong in favor of is a mycophenolate, the treatment recommendation, but conditional in favor also nintedanib. Then second drug is pirfenidone, antifibrotic agent that inhibits the transforming the growth factor beta TGF-B stimulate collagen synthesis, decrease the extracellular matrix, and block the fibroblast proliferation in vitro. Dose is up to 40 milligram per kg of body weight and is given in 3 divided doses. Common side effect is rash 30%, photosensitivity 9%, nausea 36%, diarrhea 26, abdominal discomfort, dyspepsia, anorexia is seen in this patient. Now, basically, why the in this patient there is a basically is a fibrosis which we can see in the most of the ILDs, and the fibrosis is basically is because of associated with the pollution also. Air contains something like a 75% nitrogen and 25% of the oxygen, and many pollutants oxidants are seen. So increased level of nitrogen which is seen in the uh, polluted air can exhibit a harmful effect in case of the IPF, and which lead the fibrosis in the lungs. The IPF is also associated with the there is a association with telomerase shortening, that is which is seen in the chromosome, and there is few trials which shows nintedanib and add-on perpinadone in idiopathic pulmonary fibrosis. The conclusion of this trial is that both these drugs, add-on perpinadone, had a manageable safety and tolerability profile in the patient with IPF, but there is some adverse events are seen in each drugs, but more data is required for the combination therapy. Another safety and tolerability of combination treatment of perphenadone and nintedanib in patient with IPF. The conclusion is showed relatively frequent incidence of discontinuation and adverse drug reactions for combination therapy in IPF. Further, large randomized controlled trials are needed to support this evidence. In case of disease progression, despite on antifibrotic, should we switch to other antifibrotic? No data or to suggest this or strongly support the switching to the another antifibrotic agents. When the patient is not showing any progression with the antifibrotic drugs, check is there patient is having adherence to the drugs, is there having new comorbidity like um, a patient is having hypothyroid, patient is having OSA, patient is having asthma, patient is having some malignancy, new persistent risk factors exposure is there, or new consolidation or pneumonia is there. We have to check before we have this considering the new antifibrotic drugs, and try treating other causes of add inflammatory immunosuppressant drugs in these patients. In case of intolerance to the one drug, should we switch to the another drugs? First, try the supportive measures, load reduction, and if it is not possible that all the measures patient does not show tolerance to the drugs, then you can shift to the another drugs. This is how the shift in fibrotic lung disease, uh, that is perphenadone and nintedanib, they have compared. Another drug which has come is trepsostenol. Basically, it is a drug which is used in the pulmonary hypertension, analog to prostacyclin and antithrombotic properties. Patient with pulmonary hypertension due to ILD is most commonly used. It is available in infusion, inhalation, or oral form, that is 1 milligram per ml or 2.5 milligram per ml or 5 milligram per ml. Improve exercise capacity from baseline when it is 6-minute walk test is done. 6-minute walk test is very important as far as the prognosis of all ILDs is concerned. There are three things which are important, or I must mention it. That is the lung function test where the FAC and DLCO. And third is the 6-minute walk test where the distance walked by the patient. This all these three shows the progression of the disease and the severity of the disease. Side effect of these drugs is nausea, vomiting, impaired liver function, and skin rashes. When anything is not working, then we need a patient to uh, consider for the lung transplantation. The patient which are needed lung transplantation or patient should be considered for the lung transplantation like patient those who are having UIP or evidence of NSIP. There is a decrease of FAC 10% and DLCO 15% in the last 6 months. Oxygen is less than 88%. 6-minute walk test shows fewer than 250 millimeters distance is covered or 50-meter decrease in the 6-minute walk test in last 6 months. These are the few criteria. And in India, most of the patient they consider less than um, 60 of the age. Um, no comorbidities. The comorbidities are there, then the result of lung transplantation are not that good. Lung transplantation is the only form of therapy that may improve quality of life, survival of the patient with IPF. Particularly, I am talking about IPF. The 5-year survival following the lung transplantation in IPF patient is seen in a pulmonary fibrosis and approximately 50%. About the future directions about the treating the ILD patient, targeting only a single pathway or process rather than using the combination of the agent may represent the Achilles heel of using the monotherapy to the IPF. While a single agent may have no significant impact on the clinical course of IPF, combination therapy may have impact. Selection of appropriate endpoint measures of clinical trials may be a key identifying therapies that are clearly of benefit to the pathways patient of IPF. Additional clinical research is needed for the much effective therapy in IPF and ILDs. An improved understanding of the genetics and genomics are required in the ILD, and then we'll be better in managing the ILDs. In conclusion, the diagnosis and the treatment of the various type of ILD present a considerable challenge to the clinicians or the physicians. Comprehensive clinical evaluation combined with the appropriate imaging and diagnostic procedures such as clinical history, CT, some diagnostic test like a test for the uh, diseases which are connective disease related diseases, and then histopathological evidence to the bronchoscopic biopsy or open lung biopsy or the other type of biopsy. Treatment of ILD entities that are characterized by the lung inflammation can be quite successful. In short, when there is an inflammation, the treatment of ILD is successful with the help of immunosuppressant like the corticosteroid. But when there is a inflammation along with the fibrosis there, then difficulties are more. And when there is only fibrosis is there, and that is the immunosuppressive agents are administered in this patient, but they are unlikely to give relief to the patient. And when there is a fibrotic type of disease is there, only antifibrotic drugs are there to stop the fibrosis further. However, extensive fibrosis has been established. Such therapies may have a little or no impact on the disease or disease progression. Patients with progressive disease for which effective therapies are lacking should be encouraged to enroll in the clinical trials and the lung transplantation. In summary, ILD is broad category of the disease, heterogeneous multi-system involvement and multi-complex disease where the fibrosis is there, but earlier this is the inflammation leading to fibrosis. Sometimes there is a both inflammation and fibrosis are both are seen in the disease. Symptom wise, most common is dyspnea, distressing cough, chest pain, fees, pleural pain, effusion, hemoptysis. Extrapulmonary symptoms are seen in the CTD ILD patient. HRCT shows overlapping findings, maybe cellular type of NSIP, maybe fibrotic types of NSIP, where you can see the nullular opacities, ground glass opacities, mosaic attenuation, then 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 like bronchiectasis and honeycombing is also seen. Different HRCT finding and the location of this finding can lead to a specific diagnosis that we have seen. Lung biopsy, like a transbronchial lung biopsy, cryobiopsy, thoracoscopy, open lung biopsy, are more important for the diagnostics to establish the histopathology of the disease. But most of the time, it are very difficult when patient comes to the clinician. That time they are having severe respiratory distress or severe cough. It is become difficult to perform the lung biopsy or TBL. Prognosis depend on the type of various type of ILDs. If there is IPS, that is idiopathic pulmonary fibrosis, unknown cause, elderly patient, the prognosis is very bad. 3 to 5 year patients expectations are seen when patients are not treated from the diagnosis. Thank you very much for the kind listening, and the session is open for any sort of a discussion. Hello.
Yes,
Yeah.
sir, wonderful. That is
Thank
one
you, sir.
word
It
you
is
can
a
say.
basically it is a vast topic, so it
Well,
becomes very difficult to cover all the things because HRCT is the only one thing where we can have a separate type of lectures. Probably some Amita madam may be having some lecture on HRCT.
yeah, yeah. On 2nd of April, she has promised to take this.
Yeah, she will explain
Yeah,
better about the various presentations, the HRCT in various type of ILDs, and
yeah.
which will be more specific for the diagnosis. Because we have got only one weapon with us, that is the HRCT, where we can make a diagnosis, we can reduce the differential diagnosis, and where we can initiate the therapy for the patient.
There is one question, Neha Kumari. Can we
What?
predict, yes, prognosis of patients with ILD on basis of clinical or radiological features?
Yeah. See, it is again depends on the type of ILD. It is NSIP, the prognosis is very good. Again, it is fibrosing type of NSIP. Again, the prognosis is not bad. But when it is a IPF, that is idiopathic pulmonary fibrosis, above the age of 60, involvement of the lungs, which is honeycombing, then basal distribution, the prognosis is very bad in this patient. Again, prognosis can be assessed with the help of other factors like how patient is having symptoms, how severity is the is a uh, his dyspnea, how much other factors like comorbidities are there. If patient is having secondary pneumonia, pulmonary tuberculosis, associated malignancy, then patient is having GERD, patient is smoker, and not maintaining this hypoxia, definitely this patient may have a bad prognosis. So in this patient, when there is a bad prognosis, along with the treatment, we have to give the palliative care to overall improve the quality of the life. In case of IPF, the mortality is very high. When this severe condition patients are admitted in the hospital, the mortality is as high as 34 to 40%, or sometimes maybe 50%. During hospital stay, it is 50% mortality, and after discharge after 3 months, the mortality is seen more than 63 to 73% in IPF patient. So mortality is again, or the prognosis of the disease is again consider the extent of disease which we can see in the HRCT, symptomatology of the patient, associated comorbid condition, age of the patient, whether he is smoker, associated disease, and hypoxia.
Dr. Sanjay, Dr. Sanjay, please. Another question.
So, so there is one more question.
Yeah, sure.
Why the antifibrotic agents are not useful in fibrosis due to other causes, that is non-interstitial lung disease causes like tuberculosis,
See,
while the
basically,
mechanism of fibrosis is almost same.
yeah, basically
This,
what happened
this, this
in this,
question is being asked by Dr. Neha.
yeah. See, there is some pattern in interstitial lung disease where there is a patient is exposed to some inhalation or the dust or some sort of viral infections are there, in particularly ILD patients. There is a alveolar destruction or there is a damage to the alveoli. Ultimately, the damage to the alveoli leads to more fibroblast formation around with or you can say the interstitium, leading to more thickening of the interstitium because of the more fibroblast formation. These fibroblasts, they can further, form the granulomas, and fibroblasts may lead to further fibrosis, which is totally different than the fibrosis which we can see within tuberculosis. Basically, it is a injury leading to scarring, then fibroblastic foci, then proliferation of the fibroblasts, leading to myofibroblast, leading to secretion of the collagen, and then the fibrosis. This type of event does not happen in the fibrosis which we can see in the tuberculosis. So that is how the antifibrotic does not help in the tuberculosis.
DP Singh, sir.
Yeah. So we have, as you have promised to complete this talk and even the answer the questions of our PGs, more than 1 hour, I think 1 hour.
Yeah.
That's
It was something
only,
lengthy. We
yeah,
have
yeah.
exceed some time.
So you need a round of applause, huge round of applause, but we can that. A
Thank you.
wonderful and congratulations, sir. And you have done this job very comprehensively. And as you know that ILD is a complex and heterogeneous group of disorders. And just starting from the radiological approach, this HRCT diagnostic approach, touching every fiber of this disease and even completion of this supportive therapy, this antifibrotics, steroids, even up to the transplantation. You
Yeah.
have touched every aspect of it. Fabulous talk, and we must congratulate you. And I think our PGs and our
Hope, hope.
listeners must have been benefited. And as a primary care physician, PG, it is essential to recognize early signs and symptoms of ILD, such as progressive dyspnea, cough and fatigue, and timely referral to a specialist is critical for accurate diagnosis and initiation of appropriate treatment. Because as you know, the ILD needs a good pulmonologist, a good radiologist, even a good pathologist, combination of all these to find out
And
the
sometimes rheumatologist also. We need help of
rheumatologist.
rheumatologist.
Yes, yes, sir. So thank you very, yeah, Dr. Sanjay. Yeah.
So basically, a multidisciplinary team approach is needed in order
Yeah.
to diagnose and manage the ILD cases. So it is
Yes.
not only that the pulmonologist can alone diagnose or manage the cases. So it's a teamwork, as Sir has jolly well explained. A pulmonologist, radiologist, histopathologist, and the rheumatologist. Rheumatologist. So
Yes.
all so
Histopathologist is also important.
multidisciplinary team discussion is very much needed in order to have a good management for the ILD cases.
Yes, sir. Just a minute, 1 minute.
And
We are seeing lot many cases, but mostly the diagnosis is depend on the how we read the CT scan.
yes,
If
definitely.
you have a good understanding about the CT scan and the finding, then you can definitely segregate the various type of ILDs. and that will help you to start the various type of treatment in ILDs. So CT
Yes, yes.
scan impressions are very important.
So in the
So
past,
we,
it was the open lung biopsy that was the gold standard for the diagnosis of the different types of ILD. But
Yeah.
with the advent of HRCT and now the AI,
Yeah.
the HR the radiological diagnosis is very much helpful in not only making a diagnosis of ILD but also making differentiating the type of ILD.
Type of
And so
ILDs.
yes, so that we can manage
Because
the things in a
many times
better way.
it becomes impossible to go for the histopathology because
Yeah,
patients are severely ill and they won't allow you to do bronchoscopy even.
yeah.
So that
And
time we have to totally rely on HRCT finding.
And one thing I wish to add in the management part that pulmonary rehabilitation is a very important
Yeah,
part. So
that is very important part.
that's very important.
so before closing the session, that next talk that will be on 26th by none other than Dr. Sanjay Kumar on pneumonia. And I request Dr. Ashok Arbat sir for this fantastic talk. We shall have the write-up of this ILD with 10 multiple choice questions because we are going to publish this short course, certificate course in the under the banner of ICP. All the topics of the speakers.
Okay.
Yes, request to me.
Thank you, sir.
Yeah, yeah.
Thank you very much.
Thank you. Good night, sir. And again,
Good night. Thank
congratulate
you,
you
things
for the
up, everybody.
fantastic
Thank
job.
you very much. Getting associated. I am really thankful to getting associated with you and hope so in future also. If you need my anytime, my talk, I'm willing to be there for
We
you.
loved it, sir. We loved it.
Thank you.
Thank you.
Thank you very much.
Thank you.
Bye, sir. Good
Thank you.
night.
Good night.
Bye. Good night.
Thank you, Dr. Sanjay ji, and thank all listeners. All
Thank you, sir. Thank you, sir.
Good night.
Bye. Good night.